Good morning, good afternoon, good evening to colleagues. Welcome to this week's information session on COVID-19. Just to run through the agenda, in a moment I will pass the floor to the Director General for his opening remarks. We then go into our technical and epidemiological updates, and this week the focus is on communities at the centre of pandemic preparedness and response, with Dr. Nedret Emiroglu, Director Country Readiness and Strengthening, and Dr. Sylvie Briand, Director Global Infectious Hazard Preparedness, who will be speaking and introducing other colleagues. We then have a section of the agenda on WHO's presence and action at the country level. That will be opened by Dr. Shambhu Acharya, Director of Country Strategy and Support, with contributions then from Ms. Mbanga Ghathrabwe, who is the UN Resident Coordinator for Mali, Dr. Jean-Pierre Baptiste, WHO Representative for Mali, and Dr. Liang Kupens, WHO Representative for Uzbekistan. Obviously then we will move to question and answer and conduct that in the usual fashion. And so with that, I'll ask Dr. Tedros to make his opening remarks.
Thank you so much, Jane. I would like to start by saying Eid Mubarak. Eid Mubarak to all Muslim brothers and sisters, and wish them healthy, joyful, and safe Eid. So Eid Mubarak again. Your Excellency, Harsh Vardhan, Chair of the Executive Board, Honorable Ministers, Excellencies, dear colleagues and friends. Good morning, good afternoon, and good evening to all Member States, and thank you for joining us once again. Globally, we saw a slight decrease in the number of COVID-19 cases and deaths last week, with declines in most regions. Cases and deaths are still increasing rapidly in WHO's Southeast Asia region, and there are countries in every region with increasing trends. But the number of weekly cases and deaths remain near their record highs, with more than 5.4 million reported cases and almost 90,000 deaths last week. While any decline is welcome, gains can be easily lost. In some ways, the way down is more dangerous than the way up. Over the past year, many countries have experienced a declining trend in cases and deaths and have relaxed public health and social measures too quickly, only to suffer a harsh resurgence. The pandemic is still evolving and progressing around the world. Excellencies, colleagues, let me be clear. Globally, we are still in a perilous situation. Transmission is being driven by the spread of variants, increased social mixing, the too quick relaxation of public health and social measures, and inequitable vaccination. Yes, vaccines are reducing severe disease and deaths in countries that are fortunate enough to have them in sufficient quantities. And early results suggest that vaccines might also drive down transmission. But the shocking global disparity in access to vaccines remains one of the biggest risks to ending this pandemic. High and upper middle income countries have received 83% of the world's vaccines, while low and middle income countries have received just 17% of the world's vaccines. Redressing this global imbalance is an essential part of the solution, but not the only part, and not an immediate solution. We have many vaccines for many diseases, but for each of them we still need a combination of vaccines and public health measures. The same is true with COVID-19. You must use every tool at your disposal to drive transmission down right now. Even if your country has a downward trend, now is the time to surge your capacities. Even in countries with the highest vaccination rates, public health capacities must be strengthened to prepare for the possibility of vaccine-evading variants. How quickly we end the pandemic and how many sisters and brothers we lose along the way depends on how quickly and how fairly we vaccinate a significant proportion of the global population, and how consistently we all follow proven public health measures. As you know, there have been new reports in the media about allegations of sexual exploitation and abuse linked to WHO's Ebola response in the Democratic Republic of the Congo. I'm personally appalled by these reports, and I know many of my colleagues are too. These reports jeopardize our mission and our work, but more importantly, they are a shocking betrayal of trust of the people we serve, many of whom are women in vulnerable situations. Just 10 days ago, member states were briefed by the independent commission that has been established to conduct a thorough investigation with support of an independent firm that was hired by the independent commission. This is the first time this has been done in the United Nations system. We wanted to do things differently because we want the most thorough and independent investigation possible. I also hope this approach will help us to identify the root causes and systemic weaknesses that allow sexual exploitation and abuse to happen. I want to assure member states that we take this with the utmost seriousness and that we will act decisively on the Commission's findings. Already, we have taken several steps to strengthen our policies and procedures in line with the UN system. We're embedding dedicated focal points for the prevention of sexual exploitation and abuse in all of our field operations. We're strengthening community engagement and putting in place mechanisms for reporting and investigating allegations and protecting those we serve, especially the most vulnerable. We're taking a survivor-centered approach in the deployment of personnel, and will take prompt and robust action in all cases where WHO staff are found to have engaged in sexual exploitation and abuse, including collaborating with relevant national authorities on criminal proceedings. We have implemented a new policy on preventing and addressing abusive conduct, and we are strengthening awareness and training programs targeting everyone who works for or with WHO. And we are promoting a respectful workplace to prevent and respond to discrimination, abuse of authority, and harassment, including sexual harassment. Once again, we're committed to taking whatever measures are needed to protect the people we serve. At last year's World Health Assembly, member states asked me to initiate an impartial, independent, and comprehensive evaluation to review experience gained and lessons learned from the WHO-coordinated international health response to COVID-19. After careful consideration and consultation, I asked President Sirleaf and the Right Honorable Helen Clark to take on the task of chairing this evaluation. Beyond that, this has been an entirely independent process. They selected the co-chairs, selected the other panel members, drew up the terms of reference, appointed a secretariat, and got on with the work. And yesterday, After extensive efforts to collect and analyze a wealth of information, the independent panel for pandemic preparedness and response released its findings and recommendations. We look forward to the publication of the full report at the World Health Assembly. The independent panel's report is one of several reports reviewing different aspects of the pandemic and WHO's work, including the review committee on the functioning of the international health regulations, the independent oversight and advisory committee for the WHO Health Emergencies Program, the external evaluation of the transformation agenda, and the Intergovernmental Working Group on Sustainable Financing. And I thank each panel and committee for its work. And we look forward to reviewing their reports as a totality and to discussing them with you, our member states, in the coming weeks. As always, we're grateful for your engagement with today's presentation, and we look forward to your questions and comments. I thank you. Jane, back to you.
Thanks, Director General. And just before we pass to Dr. Beyond and Dr. Emiroglu, I know that Dr. Mike Ryan, Executive Director of the WHO Health Emergencies Programme, would just like to say a few words. Mike, the floor's yours.
Thank you, Jane. No, just to introduce Sylvie and NedVet's work, and communities have been at the centre of the work we've done, both in the front line led by our country offices supporting governments and local community initiatives and really working on community resilience. Epidemics and pandemics begin and end with communities, and we've seen the powerful role that communities have played in containing this disease. We've also seen the suffering that our communities have suffered in situations where they have not had access to the services that they need. And we've seen the misunderstandings and the tensions that leads to. But we've also been fighting another challenge, and that is at the global level, managing the tsunami of information, misinformation, good information, bad information, and the new world we live in. And I would like to thank Sylvie for her leadership, for NedVet for hers, but also we're joined today by Tim Wiyeki, who's the pillar lead for infodemics, and as Sylvie and myself will have to leave to join the research and development blueprint for epidemics meeting, Tim will take the floor, or be here, Jane, to take any technical questions from the member states in relation to epidemics. And thank you, Tim, and thank you for your hard work and your team's hard work in this regard. So with that, I'll hand over to Dr. Sylvie Briand, and she'll pass directly to NedVet, or is it the other way around? It's the other way around, okay.
Thank you very much, Chair, and good morning, good afternoon, good evening to member states joining us. I will try to give you an update and a summary on WHO's approach to community-centered pandemic preparedness, readiness, and response efforts. Can we have the slides, please? As a follow-up of Mike's introduction, yes, the communities are at the center of the response, and they are the first exposed to any threat. And they are always also the first responders, and they play a critical role in prevention and control. And taking that fact, also that they have to be taken into account in their diverse communities and contexts, like looking into not only the health, but also the other determinants like social, economic, environmental, as well as social science and behavioral insights. Next slide, please. And our approach is putting the countries or the communities also at the center of health emergency cycle. So it is not only at the response that we need to have systems, structures which are sustainable and long-term institutional resources, as well as investments to be able to address all elements of the emergency cycle, which starts from preparedness, readiness, response, but at the same time, the recovery. So some of these functions that are highlighted are extremely critical to be able to support the communities. And that's the WHO's systematic approach on looking into what are the risks at the community and how could we prioritize the immediate actions in order to be able to fill those gaps. And it takes also an all-hazard emergency preparedness and response planning. So it's not only the infectious hazards that we are concerned about, but also the natural disasters. And we know also that some communities actually are much better prepared and ready for some of the natural disasters like earthquakes. And then the whole issue is looking into the risk and risk mitigation prioritization and enforcing the early warning and alert system, but also ensuring the full alignment of these services, community-based leadership and services with the health services and the public health functions. Again, taking the experience we have from the COVID response, and as it will be elaborated more by Sylvie later on, the risk communication, community engagement aspect, as well as the accurate information, how to manage the infodemics. Next slide, please. So I will summarize kind of lessons learned from the Ebola, Zika, and recently from the pandemic on how to be able to support the countries, to be able to go down to the communities to ensure sustainable, ready, resilient communities. So it has to be clearly linked to the national system and has to be supported by the regional and global networks and mechanisms. And the WHO's approach is promoting an inclusive governance, taking the whole of society and engaging all major players, not only the health, but also the other sectors, civil society, influencers, religious groups, whoever is critical in mobilizing the communities. Then the real challenge is how to sustain those structures and resources for innovative community-led solutions. And this is the part we are seeing in also in COVID. You can sustain those for a limited period of time, but what are the models and the means to be able to do them for longer term? And of course, that is done with a broad range of partners, using the different networks and coordination and knowledge sharing platforms at all levels. And WHO is preparing also the strategies, norms, guidance, and tools specific to the communities and their context to be able to have the people-centered and community-led actions. If we could move to the next slide, I want to just highlight three different examples to give you an idea of what those actions are leading to. Next slide, please. Yes. And one of the areas I would like to emphasize is the importance of mapping the risk and vulnerability and that immediate action in scaling up the operational readiness for communities for any imminent threat. And one of the examples I want to give is just recently the Ebola cases we have seen in DRC and Guinea. The action was to work with the regional office and country office and also the local governance mechanisms to have an immediate and dynamic risk and vulnerability mapping to guide what will be the immediate actions and what are the areas that are needing the scaling up and support in the neighboring communities. And actually also the critical factor is how to engage the communities in operational readiness and response, listening to them and trying to define their needs and be able to reply to those. So that has proven to be quite efficient, and this is one of the examples I would like to give. Second example I would like to give on how WHO works together directly with the civil society organizations, engaging them at the grassroots levels. And that's work we do in 36 countries, engaging more than 60 trusted civil society organizations, and with a special focus on looking into somewhat vulnerable populations in the COVID response. And they're like the civil society who's particularly working with the migrants, refugees, internally displaced people, youth, women, and indigenous population, and so on, and trying to, again, use them as mediators to be able to listen to, and listening to and building that trust is critically important in engaging the communities to be able to address the needs of the communities, to define what the priority needs and actions are. The next slide, please, will be the last example I would like to give, an acknowledgement and recognition of a strong partnership which is looking into risk communication and community engagement specific to COVID. This is between WHO, UNICEF, IFRC, and FORN, and it has proven to be a rolling out to the communities and efficiently engaging different local partners in improving the quality and consistency through harmonized and coordinated risk communication messages. Next slide, please. And there is a platform which is contributing to these initiative and the coordinated approach to engaging the communities systematically, and actually serve as the social data collection and analysis. And I advise you, if you have time, to visit the website. Thank you very much. Over to you, Sylvie.
Good morning, good afternoon, or good evening. I'm very pleased to introduce you to the subject of infodemic and to also make the link with how we engage community through this activity. So, next slide, please. So just to highlight that infodemic, as Mike already mentioned, is the overabundance of information, accurate or not, that spread alongside an epidemic or a pandemic. And that makes it difficult for people to make decisions for their health. And we have seen during this COVID-19 pandemic a very strong infodemic, and a lot of mis and disinformation has spread as well. So we differentiate misinformation, which is just inaccurate information, from disinformation, which is also inaccurate information, but with the intention to mislead. And Dr. Tedros, more than 1 year ago already, highlighted the threat of a major infodemic, and saying that we are not just fighting an epidemic, but we are also fighting an infodemic. Next, please. So infodemic is not new. We have infodemic every time we have an epidemic. But what is true is that the infodemic during this pandemic have been really impressive. And we learn again and again that infodemic cannot be eliminated. We can just learn how to manage it better. Next, please. And indeed, during this pandemic, we have seen that the access to internet now, more than half of the world population has access to internet and social media, makes it even more challenging to manage the infodemic because it thrives online, but also offline, and it requires really a whole of society and whole communication ecosystem approach. But if we manage well infodemic, it will also be very effective to better manage epidemics and pandemics. Next, please. So managing infodemic, it's not only suppressing messages that are not accurate. It's really a package that goes from the science and evidence-based information on infodemic management to interventions. And here I've highlighted 4 main interventions: listening to concerns, communicate risk and distill science, promote resilience to misinformation,
engage and empower communities. And of course, it leads to an impact on behavior change, but also on mitigating the epidemic risk. I will only highlight two of these important interventions. Next, please. Thank you. The first intervention is really important, and Nedret also mentioned it, it's listening to population concern. And we have developed an online tool for that, for countries to be better equipped to listen to population concerns. And I would like to give the floor to Christine Sersnak, who is part of the infodemic management team at WHO headquarters, to present this interesting tool. Christine, you have the floor.
Thank you very much, Sylvie. And I will take a moment to bring up my screen because I'm delighted to show this platform in real time together here today. Excellent. So I invite everyone to go to the link that I shared in the chat, and you can actually access this dashboard in real time. And before I show you some of the key features of this tool, I wanted to provide a little bit more context about why we developed this initiative. I think all of us are on the same page about the value of social listening to assist with epidemiological monitoring, preparedness and response, and to provide valuable information to help inform policy decisions. By better listening to the public comments that communities are sharing, it may be possible to detect an emerging health threat much sooner and better target a response for better resource use efficiency and higher impact. Now, polls and surveys and focus group data and knowledge attitudes practices data, these are all important and they serve a purpose. But one of the challenges that we've been hearing from our country teams is that by the time the results roll in, the conversations and public understanding, they've marched on. So there's this sense that we're always on the back foot reacting to things rather than being able to respond in near real time. And that near real-time monitoring capability is really one of the reasons why we've developed EARS. And sharing some more context why we've invested in this pilot to develop this as a tool for regional and country teams. So from the perspective of running an infodemic management team in support of community engagement by monitoring those changing concerns in connection to the response and evaluation functions, currently there is a lot of heavy lifting associated with trying to cobble together a bunch of different niche services and sources of data. And this is taking a lot of time, and one of the aims of EARS is to save teams time, something that I think we can agree we always need more of during an emergency response. So this platform is really serving as a one-stop shop for all different types of data to be brought together for triangulation and meta-analysis to more easily and rapidly inform team decisions on how best to target their efforts for maximum impact. So the EARS backend, which I'll show you after the public dashboard in a moment, it's completely customizable and can combine the semi-automated social listening data that we're pulling in from online sources with structured data from CAP surveys and other offline sources. And the reason why there's a backend is for authorized user access only in case some of those data do need to be kept as private. But an important point I want to make here is that other analytic services in this space, these subscription services, they can come and go, and none of them is particularly comprehensive. So we really saw a need to invest in infrastructure that can gather public health relevant data from different sources that's less subject to the changing whims of private companies in order to help our teams better design and adapt their health emergency response. And I should emphasize that there's certainly value for some of these other services in terms of corporate communication to get an idea of how products are performing and news coverage, but really at best they're giving us an idea of engagement with content and maybe a basic sentiment analysis, but it's not really giving us the insight that we need from a public health perspective on whether people are talking about an issue because they're having difficulty implementing particular public health and social measures, or if they're seeking information because of confusion about a new policy, because of a conspiracy theory that's circulating, for example. So there's also, I think I should flag up here a challenge in access to these other services as well. So in our first Global Infodemic Manager training program, we had trainees from the Ministry of Health who were they requested access to one of these services and were denied access. And so it's really important here that we're providing a tool that's accessible to public health teams. So looking at the platform together here, we're looking at the open access dashboard, and we are currently covering 20 countries in 4 languages, and I'm delighted to share that as of next week, we'll be covering 25 countries and 5 languages. And the aim here is really to be able to use the WHO social listening public health taxonomy for COVID-19 to be able to save teams time by quickly focusing in all of the content into categories relevant to COVID-19. And although we're focused here on COVID-19, I should say that this approach can actually be developed and a taxonomy developed for dealing with myriad health issues, looking at Ebola, influenza outbreaks, routine health programs, looking at tobacco, alcohol, etc. So here we have the 39 different categories that are of interest, and we can do a quick trends check to see how conversations are changing over time. Now, these are based on volume, but something that's really valuable here is to be able to actually consider how information is changing based on velocity. So what are the key issues that are coming up so we can do horizon scanning and try and get ahead of some of these issues before they're going viral. And coming down here to look at this heat map, I also want to flag up that here on the y-axis, we have the countries that are currently in the platform. On the x-axis here, we have the different categories for our COVID-19 taxonomy. And we can look at a quick breakdown by volume, by rising, or interestingly, we've disaggregated by gender. So looking here at this heat map by gender, we can pick up, for example, where in particular countries there's a very strong skew in the conversation, either male-driven or female-driven for a particular topic. And the reason why this is especially valuable is that it's going to empower teams to be able to take more gender-sensitive approaches to the response. So I encourage you all to explore the front end here, and I want to take a moment to show us the back end. So the login then takes us to a benchmark analysis where we can actually at a glance be able to pick up what are the key outliers for these 39 different topics about COVID-19 to be able to quickly focus risk communication and community engagement team efforts to figure out where they need to do a deeper dive in exploring particular narratives that might be driving the conversation. And so if we want to explore a particular outlier, we have the opportunity to scroll through the list of countries here and see which one we want to do a deeper dive in. So for example, why don't we pick up Nigeria? And that takes us to the page where here's where we are able to actually do a deeper dive into the specific narratives about a particular topic. So for example, there was a source of confusion coming up recently that we're seeing emerge in Nigeria about whether the absence of side effects after having been vaccinated may be indicative of having received a falsified vaccine. So this kind of information is incredibly valuable to allow teams to quickly develop the necessary information to help identify key information voids and fill that. And I should say that we also have the capacity to disaggregate the analysis by questions and complaints so that we're able to go beyond simple sentiment analysis to actually quickly zero in on what are the critical information voids that need to be filled and the key complaints that need to be addressed. So with that, I will stop the share here and turn it back to you, Sylvie, and happy to take any questions. Thank you.
Many thanks, Christine, for this presentation. And I encourage you to see online this tool, and we are happy to work with countries to develop specific features if needed for your own setting. And really, this tool enables us not only to understand the trends of the conversation in the population, but also the intensity, how the subject is important at the given time, but also the sentiment of the population, if people are looking at this with anger, with fear, or with compliance. So I think this is really a very comprehensive platform that helps very much to develop messages. So if I can have again my slide set. And it's very short. I just would like to highlight another type of activity we do with community. The WHO EpiWin, which is the WHO Information Network, has made relationship at the beginning of this pandemic with different important groups, faith-based organization, youth organization, employers organization and workers organization. And we have regular communication and dialogue on issues that are sensitive and regarding COVID-19. And what we do together with those community is first we co-develop guidance, and we try to have guidance, for instance, on transmission that are adapted to the settings of those communities. For instance, what about transmission at work? And so we co-develop those guidance to make sure that it really fits with the context in which they are going to be applied. We are also collaborating in the development of messages and material. For instance, with the youth organization, we have developed the design, we call it the Design Lab, where we engage with the youth organization to design creative and engaging and relevant communication material with their words and their vision of the world as a young people. And finally, we also facilitate virtual dialogues through webinars and to answer questions, specific questions that some communities may have, because general messages sometimes doesn't answer really the concern of certain minorities or certain people working in specific conditions. And so since the beginning of this pandemic, WHO EpiWin has hosted 93 COVID-19 webinars with participants from 149 countries. Next, please. So one particular important co-development was the development of guidance with faith community, because as you know, since the beginning of the pandemic, we have seen very often an increase in transmission following religious gathering. And today is Eid Mubarak and also the Ascension, so many people will gather in the world, and it's very important that those religious gatherings are done in a very safe manner. And so we co-develop with them the guidance to make sure that the technical aspects of COVID-19 transmission can be applied in different contexts and different practices in faith communities. Next, please. Some people may believe, especially after the presentation of Christine, that we work only with online, but it's not true. We have developed a number of partnerships with other UN agencies, UNICEF, UNESCO, IFRC, and ITU, and others to also leverage all the networks available in the world to be able to communicate with the global population. And so, for instance, this is an example of a project that was developed with UNESCO, where we have leveraged more than 2,500 radio stations in 128 countries to not only listen to population concern, but also to spread out accurate messages about COVID-19. Next, please. And finally, I just want to highlight that we have trained also infodemic managers, and I really thank all the member states who have accepted to delegate some of their staff and civil servants to this training, so that now we have a workforce of 268 infodemic managers across the world. We are engaging in the second training cohort in June. Unfortunately, the cohort is already full. We have had more than 700 applications, and we can only accept 250 people. So, but we hope to organize many more trainings in the near future. Next, please. Also, I would like to highlight the progress we made in the infodemiology. Infodemiology is a scientific discipline created to help us to gather the necessary evidence to guide our intervention to manage infodemic. And we had a global conference in June last year, and which enabled us to highlight 49 priority research questions that need an answer urgently so that we can better manage the COVID-19 infodemic. And those questions are around how do overwhelming amounts of information affect behaviors in emergency, and what interventions are effective in addressing it? How does online behavior affect offline action? How does infodemic affect cognition and influence seeking health services? How does the role of policy intervention successfully address and mitigate health information? How does the infodemic affect closed networks and vulnerable populations? Next, please. And I will just mention the EpiWin slide set that you receive, I think, attached to this agenda on a weekly basis, and it's shared by our colleagues from governing bodies. Next, please. You can also look at all the videos, messages, posters, and things that we have on our website. And I would like to thank all the teams at WHO who are contributing to this importantly, and DCO to help us also to spread out those messages. And if you have difficulties to navigate into our website, we are very pleased to help you, and don't hesitate to contact us if you need specific materials for your countries. Next, please. And I just would like to thank you. And here on this slide, you see a button that will enable you to also go to a specific part of our website, and you can also have access to our newsletters where you have information, regular information on all what is happening in the world of infodemic management. So thank you very much for your attention.
Thank you very much indeed to Sylvie and to Nadret and to Christine for that fascinating presentation. There'll be a chance to ask them questions, obviously, under the Q&A or ask colleagues. I know one or two colleagues have to depart to another meeting, but we will be able to answer your questions. So we move quickly to the second part of our agenda. And first, we're going to hear from Dr. Shambhu Acharya, who's our Director of Country Strategy and Support. And then we have our other guests, but I think we'll go first to Dr. Acharya, who will introduce this next section of the meeting. And I would ask all colleagues to be as concise as possible. It's important that we leave an opportunity for our member states to ask questions, please. So looking for conciseness from everyone in their presentations. Thank you. And Fabia, I know Dr. Acharya is on the line. If you could introduce him, please.
Thank you very much, Madam Chair. And Dr. Acharya, over to you.
Thank you, Chair, and thank you.
Indeed, we can, loud and clear.
Thank you, Chair, and good morning, good afternoon, and good evening. I'm going today to speak about WHO's work in countries during the COVID-19 pandemic response from the perspective of our colleagues working in the WHO country offices. I'm also joined virtually by WHO and UN colleagues from Mali and Uzbekistan, who will shortly share their experiences with you. This presentation is based on some of the data we have collected from country offices over the past year through our internal country presence survey conducted with 149 country offices and through the collection of country case studies about WHO's work in around 100 countries. Thank you for changing the slide already. So shown here in this slide are some of the key findings from our latest report, which will be available as an information document at the upcoming World Health Assembly, which is a WHO Country Presence Report 2021. As you know, the WHO has one of the largest country presence footprints of all the UN agencies, and our country presence has always been a key mechanism for WHO in delivering technical cooperation to our member states. During COVID-19, these offices have played an even more important role in supporting countries to respond appropriately to the situation on the ground. This particular slide shows the surge in WHO's human and financial resources to the country level in order to strengthen existing office capacities to support in response across the globe. I just want to highlight a couple of examples here. For instance, the 60% of existing international staff in countries were repurposed at some stage to support the COVID-19 response. Similarly, an additional 1,200 staff and non-staff were deployed across more than 100 countries. And almost all country offices were supported through additional capacities from WHO's sub-regional office, regional office and headquarters, with a further 217 deployments to date from medical teams and Quran. Next slide, please. From the outset of the COVID-19 pandemic, we have also been working closely with our WHO representatives, country teams, and our regional offices to document their work in the form of case studies. And our goal in doing so was to add context and texture to the globally aggregated results data. It has become also a component of the WHO's results report. You can find some of the case studies in the midterm report there. To better highlight the work of WHO.
Dr. Acharya, just sorry to interrupt just a moment, just a reminder to all speakers just to slow down a little for the benefit of interpretation. Thank you so much.
To better highlight the work of WHO in relation to the wider efforts of the governments and partners, to foster sharing and learning about what is working well across the organization level and between regions and countries, and to highlight and better understand common challenges faced in working at the country level. These case studies are also helping to understand how WHO's work at the country level contributes to the achievement of the 13 General Program of Work strategic shifts and the transformation agenda. Next slide. In terms of the first strategic shift, there is certainly evidence of WHO's stepped up leadership in countries during the COVID-19 response. I won't go into the details, but would like to highlight a few indicators that help to identify the areas in which WHO has led. And one example is 62% of the WHO country offices activated their incident management support team before the first reported cases of COVID-19 in the country. And in terms of leadership and partnership, WHO has taken a lead role within the UN country teams in almost 3/4 of countries for a more coordinated response. And you can see in the slides, we have highlighted 4 countries. Pakistan and Somalia have taken the lead, particularly on the early action and the partner coordination. Costa Rica is a good example of how WHO has addressing equity, human rights, and gender in the response of the COVID-19. And the Maldives, WHO was able to help to design a multi-sectoral approach to address the risk and needs of migrant workers returning home during the early months of the pandemic. Next slide, please. Now I'd like to go towards the second GPW 13 strategic shift, which is about driving impact in every country. WHO has been using different approaches, shown here the 4 different approaches, and tailoring delivery at the country level, depending on the needs and the context of each country. Here, you see some key outputs and outcomes with respect to country level work. And one of the most fundamental areas where WHO provides support is in the upstream area of policy dialogue and the adaptation of global guidance to the local context. Our country presence survey data shows that in February 2020, 81% of our country offices had already initiated support to the national government for the development of the national response plan. In the area of strategic support, WHO has supported whole of society approaches, as Nedret said earlier, to improve the effectiveness of the response, and has continued to monitor and focus on protecting the health system and essential health services. In the area of technical assistance, WHO took a lead role in capacity building at the national and often sub-national levels to ensure that all pillars of the SPRP were being addressed. As early as March 2020, 4 out of the 5 country offices had already initiated hands-on capacity building programs in key areas such as surveillance, labs, clinical management, point of entry, and many more. WHO's country capacity for technical assistance have grown considerably during COVID-19, thanks to missions and deployments from the regional offices and the Goran partnership. And finally, in the area of service delivery, by March 2020, 83% of WHO country offices had already initiated supply chain and procurement support to countries. This included quantifying existing domestic stockpiles and estimating future needs using scenario modeling, while also sourcing and manufacturers and even supporting local manufacture of simple supplies such as hand sanitizer. Next slide, please. And this is some of the examples of country case studies, and this illustrates the differentiated approach to supporting our member states, what kind of support we are providing in policy dialogue, what kind of support the WHO is providing on strategic support, similarly on the technical assistance and service delivery. I don't want to go into the details because these all are available in our COVID case studies report, which has the link, and you all can have access to that link. And I'll give you the link in the next slide. Next slide, please. We also requested our country offices to really identify some of the enablers and challenges in the response to the COVID-19. This is just a summary of some of the enablers and challenges. Of course, these are not exhaustive lists. They were some sort of a top 4 or 5 enablers and challenges for the internal and external actors in the COVID-19 response from the perspective of our WHO country teams. You will find more detail in these enablers and challenges in our country presence report, which will be available, as I said earlier, in the upcoming assembly as an information document. We do have a summary report, and also we have a full report. And many of these are probably not surprising to any one of us because these are something that keep on coming. Several initiatives of the WHO program and the transformation agenda and other interagency mechanisms are underway with the goal to address these challenges in future. Of course, we need a strong WHO country offices, not only to be ready for the next emergency, but also to catch up on the SDGs and rebuild the resilient health systems. Next slide, please. And just I want to give you highlights on the key resources available. If you would like to read more about WHO's work and presence in countries, here are the links to some of the key resources. Of course, in addition to the huge amount of information available in the regional and country office websites on the work about WHO's work in countries. As I mentioned earlier, the collection of around 80 countries and WHO work with governments and partners throughout the COVID-19 response in 2020, which is available publicly. It was published, and I think this is the first report there. You can see country case studies 2020. And there is also a weekly operational update produced by the country technical support in the WHO program. This is published on a weekly basis, and a number of country case studies are also summary of that is presented there as well. And the 2021 country presence report, which contains an enormous amount of information that can help to deepen the understanding of the global community on what WHO does in countries, how do we do it, with whom we work, and what is needed to overcome the challenges for achieving results and impact in countries. And the final slide is, I would like to hand over the floor to the chair to introduce our colleagues from Mali and Uzbekistan. Over to you, Chair. Thank you so much. I'm sorry if I've spoken a bit faster earlier.
Thank you very much for that. Again, more rich content there in the presentation. Just to flag to our next 3 speakers that I do want to move to Member States question and answers no later than 1:45, please. So I think everyone can do the maths on that, please. So We'll go next to, delighted to introduce the UN Resident Coordinator for Mali, Ms. Mbaranga Hasrabwe, and Fabia Longquist, our moderator today. I'll ask you, Fabia, to introduce the next three speakers and not come back to the chair, but just to continue. Thank you.
Thank you very much, Madam Chair. As mentioned, we now have the pleasure of inviting Ms. Gasarabwe to take the floor, and over to you.
Thank you very much. Distinguished delegate, I just want to highlight the work we have done here in Mali within the UN country team and the reform, by the way, the UN reform context. I think it's a very good case study to see that the COVID, a crisis like COVID, has united us very, very closely and has shown that we are one UN. As you know, Mali is an integrated mission. I serve as a deputy SRG and a resident coordinator and humanitarian coordinator. In the same time, when this, we had the first case which appeared in 25 March 2020, we have to deal immediately, engage the national authority, engage the UN, engage the partners to see how we can face this tragedy coming up, this pandemic. And immediately we had the chance to have a Minister of Health who was very engaged to gather all international community together with UN system. And WHO was really in the middle of everything to orchestrate some of the understanding of this disease. Then we had a system inside the UN when we have to face 19,000 staff. When we say 19,000, is the UN MINUSMA, which comprised by military, police, uniformed people, and the civilian. We have almost like 5,000 civilian and 13,000 people in uniform. So you can imagine the big challenge we have faced, because the whole UN system, especially MINUSMA, has to totally transform the way the military live in their caserne, the way the civilian behave. So we have to have quickly a structure. Next stage, please. Next, if you can just show the structure. Next one. So this structure was quickly, immediately inside the. You see, the crisis manager was the SRG, the Special Secretary General. The second was the outbreak coordinator, who was me as deputy SRG, but resident coordinator, uniting the whole UN system, but also linking with the national authorities through WHO. And the WHO was really delegated to engage with the Minister of Health, the partners, to see quickly how, as a UN system, we're going to work as one UN, how we respond quickly to the national plan. The national plan was designed, and immediately we had established the task force, and the task force was established in 7 components. And this really structure helped us a lot, because it was really dealing how the crisis management, it composed by with all UN system, agencies fund program, and together with MINUSMA, the police and the military component, how we're going to face this tragedy, not only responding to the national plan, but also to respond how we're going to quickly engage ourselves in our behavior, and how we're going to also respond to COVID for our staff. And we had the number one, the information management to flow, to make sure that we engage all of you, Geneva, New York, for what we are doing. We had also to see how it impacts our mandate, and also how we engage national authority, the security component, the strategic communication, the human resources, and aviation. Because we have to face 1.3 million kilometers, and Mali is a huge, huge country, and we have to face also that the region were much affected, and also response. So the 70 million was the plan requirement for the resources, and we mobilized the 23 million as the UN. And thanks again to this UN reform, we're convening authority and delegated to WHO to help us in technicality, also engage with the national authority, and to continue to serve as the link of national plan, and at the same time resource mobilization, and respond to the regional component. So I hand over to Jean-Pierre Baptiste, Dr. Jean-Baptiste Baptiste, because he's the one really who's really the focal point of what we do in behalf of UN agencies when we engage the national authority. And again, I really want to conclude saying that COVID has shown us in the UN reform that we can be united as one UN and work as in a one UN spirit. Over to you, Chair. And thank you very much.
That's terrific. Thank you so much. Really insightful to hear about that work at country level as one UN team. And I think we're now going to go to Jean-Pierre for the second half of the presentation on Mali.
Thank you, Madam Chair, for providing me with this opportunity to present the work that was carried out in Mali. And thank you to the resident coordinator for having set the background. I'd like, first of all, to insist on one point. The country preparation from the 2nd of January 2020, the rapid interventional teams on a national level and district level at the ports and borders, the national coordination, the full diagnosis with 4 operational laboratories, and the increase in beds for isolation in hospitals, and the increase of preparations for treating patients and the regional teams that were set up, as well as the implementation and establishment of an incident manager team. That meant that we were very early in January having an intervention from the WHO, which helped us to really be prepared. And I'm not going to go into the details, but the coordination mechanism has been presented, and the United Nations response has also been presented. I'm going to give you some of the key results of the support that we've had from the United Nations system. So we could give 50 examples. This support, this one UN approach, facilitated the work for the WHO, because we had all the partners and all the United Nations system working under the regional coordinator. So you can see the UNHCR, UNICEF, WHO, MINUSMA. Mali is a very complex country where the security situation creates many challenges. So to just give an example, sending material to the interior of the country cannot be done by road. So MINUSMA allowed us to take that material to the regions. Then the second point is that all the leaders in Mali prepared a response plan that were fully financed by MINUSMA. Next slide, please. So you can see that the various agencies have worked and how we were able to support on a national level the management of stocks with the specialists from World Food Programme, the increasing capacities for warehousing and stocking, the assistance during the allocations with assistance and financing from the European Union, and ensuring that we provided health prevention measures for the electors, and the involvement of the community above all, and the support for other healthcare systems and services which are essential, including vaccination. Next slide, please. So I just wanted to give you a brief overview of vaccination with some figures. You can see them here. So it's the whole of the United Nations who are involved, and we also have vaccination within the United Nations system for MINUSMA, and those in the agencies of the United Nations were supplied by New York and other areas. So we received 373,000 doses. So if we could move on to the next slide to talk about the lessons we've learned. What I can say is the United Nations were able to be recognized thanks to this one UN program and approach with this multi-dimensional response to COVID, which was rapid and coordinated. And in terms of communication on COVID, which was very good at reducing the uncertainty that existed. And we've been able to set together a communication team, not only to fight fake news, but also to present the correct information to the populations. And this multidimensional adapted response has ensured that we left no one behind. There were also, of course, many challenges. There was the slowing down of the implementation of country programs, the issues with supplies and logistics. But in general, the specific nature of Mali was through this one UN approach meant that we were able to mobilize resources and manage better. It meant that we reached the populations more easily and that we involved civil society. So one UN, Madam Chair, is a reality in Mali. And when you talk to the national stakeholders, you can see we were able to use community stakeholders and actors. And the specific nature of Mali was also that we had psychosocial support with psychologists across all the regions of Mali for COVID-19 patients, their families, and the staff in the healthcare. So in Mali, we've used COVID-19 as an opportunity to strengthen our health systems at the country level. And if we think about the presentation on the political dialogue, the technical assistance and the service provision, we can say that that was not only done with the support of the WHO, but all of the United Nations agencies. Thank you very much. And I'll be available for questions. Thank you.
Thank you, dear colleague, for that. And we'll move swiftly on to the last speaker. And please, I would ask that we finish at 2:45 to go to member states for questions and comments. Thank you. And over to Dr. Liane Koopmans, WHO representative, Uzbekistan.
Thank you very much, Madam Chair, and Eid Mubarak to all. Let me reflect a little bit indeed on more or less the WHO support which we were able to give during the COVID crisis and how we did all that. Uzbekistan is a country in Central Asia, has 34 million people, and it is at the moment in the middle of an all-sector reform and a huge emphasis with extreme government commitment for a health sector reform. The epidemic started in March only. It really reached a peak in July, August, September, and then it really went down. And now, unfortunately, we are in a new epidemic as we have the variants in the country. Now, a few words on how we supported with early readiness, with comprehensive response, with coordinated response, focus on the future and the non-COVID issues, but also how we did it and what are the lessons learned. So with regard to the early readiness, already in January, we started to support the country as much as possible with hospital readiness, with simulation exercises at the points of entry. Remind you, Uzbekistan has 53 entry points. We did also some laboratory evaluations, etc., to be prepared. It was kind of the silence before the storm because we were all waiting like, when is it coming? So in March it started, and that's the time when we accelerated the support as WHO to provide, first of all, comprehensive COVID response support. We helped them with the forecasting, with the scenario planning. We used the 3 WHO tools, how to estimate the number of beds, how to estimate the intensive care unit equipment, the human resources, etc., etc. We also adapted all the global guidance we got, and a massive amount came out on a daily basis to adapt that to the country level, but also to translate that in 3 local languages, in Russian, in Uzbek, in Kazakh, Pakistan. Major challenges. Then we provided lots of technical support, and I repurposed my country office team into infection prevention and control, into risk communication, case management, laboratory support, surveillance, procurement. All that was needed, and on a daily basis we provided that support. Beside that, a lot of providing critical supplies, with a lot of support, of course, from the regional office and the headquarters. Having said that, in the middle of the crisis, WHO, together with the Ministry of Health, sitting together on a daily basis, we said, let us be careful. We can not only focus on COVID, of course. So this was really the time, in the middle of the crisis in Uzbekistan, that we said, okay, let's not forget the immunization programs. We were also facing a measles outbreak, so we had to deal with that. We had to continue the routine vaccination program. We were introducing the HPV vaccine also. And beside that, we had a massive issue also with the non-communicable diseases. And more than ever, the government realized that non-communicable diseases were the root causes of why so many people passed away or got into the hospitals. So all that we did. In addition to that, we were able, as a country office, to continue to support the government with the health sector reform. The health sector reform towards universal health coverage through primary health care. And we managed to continue to do that with a massive commitment from the ministry, from the government. But beside that, we were also stepping back, like what does it mean? We can not only focus on COVID, we have to prepare for the future. This is a country which is facing enormous health system challenges, and as WHO, we are helping them to develop health information system, introducing state health insurance, turning around to primary health care, service delivery. But then we were like, we have to also address the IHR. The country realized that the IHR implementation was a little bit not as good as it was, so they decided to do a joint external evaluation of the IHR, which is a systematic approach to look at all the system weaknesses in the country. So while we are giving the response to the COVID, we did all the other things at the same time. But how did we do that? Well, first of all, I think we have to recognize as a WHO that we built a foundation of trust and collaboration with the Ministry of Health.
Dr. Koopman, I'm just going to ask you, please, if you can bring your remarks to a conclusion in a minute, please. I'm sorry, it's never easy to be the last speaker when there's been a lot of rich content during the session, but 1 minute, please, and then we'll go to Q&A from member states.
All right. So the importance of the trust with the Ministry of Health, which allowed the WHO to convene meetings and partnerships, etc., but also the repurposing of the staff, but do it in a smart way, that the country staff remained motivated to do the job they had to do. Massive support from the WHO headquarters and the regional office. This is a truly example of the whole of the WHO approach with the incident management teams, with the regional office and the WRs, but also the surge capacity from the regional office. And lastly, some of the challenges, because Madam Chair, I think it is important to also listen to the challenges. While we had the COVID epidemic, we also had the measles epidemic. And as we are speaking now, we have a polio risk in Central Asia. So we have to deal with the different epidemics at the same time. Then what is important to realize, the need for flexible funding. We need a kind of emergency budget at the country level to be able to deal with the day-to-day operational challenges to support. For example, the government approached me like, you don't have IT equipment, we don't have IT equipment. We want to have the webinars with your headquarters and regional office benefit from it. So this type of support was needed. And then also...
I'm so sorry to have to cut you off, but we are going to have to close the presentations from the Secretariat there and move to our member states. But it was short but very impactful, and please stay on the line in the event that there are questions. So I'm now going to hand back to our moderator, Fabia Longquist, and ask to bring member states in. I suggest, Fabia, that we bring all those who've indicated in one block, and then we'll go to very quick responses from the Secretariat. Thank you.
Thank you very much, Madam Chair, and thank you to all of our presenters. We would kindly ask those member states wishing to take the floor to please raise their virtual hands. And with that, may we first invite the distinguished delegate of the United Kingdom to be followed by Canada. Thank you.
Thank you very much, and thank you for those fantastic presentations. Communities are at the heart of the pandemic and the response, and we certainly welcome more updates from the front line in future updates. And it's reminded that the poorest, especially women and girls, are most vulnerable to threats during health emergencies. And so we welcomed the DG's update on the very concerning allegations from DRC on sexual abuse and harassment. As you know, the UK has a zero tolerance approach when it comes to sexual exploitation, abuse and harassment. And that extends to all international organisations that we fund, including the WHO. And we are deeply concerned about these allegations. We were really encouraged by the establishment of the Independent Commission late last year, but we've repeatedly voiced our concerns about their slow progress to act, particularly in the interest of survivors. And we expect this to be given the highest priority, with robust action taken where allegations are substantiated. And we would please ask for an update quite quickly, building on the DG's comments earlier during this session, as soon as possible. Thank you.
Thank you. May we now invite Canada to be followed by the Netherlands.
Thank you, Fabia. Good afternoon, colleagues, and Eid Mubarak to all those celebrating today. Just want to join the UK in sharing Canada's deep concern on the new reporting of allegations of sexual exploitation and abuse on the part of WHO staff. And member states, I think, have been very patient with the establishment and operationalization of the Independent Commission. And we really hope that this brings value and that it brings justice and accountability for survivors and helps lead to the systemic changes that are required at WHO to prevent this in the future. Second, I would just like to thank you for all of those presentations, and in particular, those from the country level. It's always really welcome to hear from WRs and to hear about the challenges and the successes that you are experiencing, and nice to hear about the joined up approaches and the effectiveness of the UN development system reform in Mali. And I think we could have a whole session on this. It would be good to have regular sessions just on this, so we can interact at the country level. Last week we read with interest the evaluation of the transformation, and we picked up on the comment that more needs to be dedicated, more attention and resources need to be dedicated in the transformation to the country level. And I don't think we have the time today, but I think it would be really interesting to hear from WRs about what that forward agenda needs to look like to strengthen WHO at the country level through the transformation process. And you've already addressed that. Some of you have addressed that a little bit already today, but further thoughts on that would be welcome, and we'll certainly read with interest the reports that you mentioned about country presence. Thanks very much.
Thank you very much. And may we now invite the Netherlands to be followed by Norway.
Thank you very much, Chair, and thank you to all the presenters of these very informative presentations. Eid Mubarak to all of those celebrating today. The presentations had one underlying theme, and that was trust. The presentation showed us how important it is that, we scale up production, we give worldwide access, especially to the vulnerable people. It also showed us we need to build trust with them. They have to trust the vaccine. It was showed when the presentation was there on the infodemic. They have to trust the vaccine, they have to have access to it. And we all know how difficult it is to build trust. It takes years and it goes quickly. And that's why we are so concerned about the situation, the Ebola situation in the DRC. We've known about it. We know there's an independent panel. We are grateful for that, but it takes too long. It takes too long to get the right information out. And this does not build trust. The whole situation there for the people on the ground, it doesn't give them the trust that we need them to have in order to get better, in order to be able to fight Ebola, in order to be able to fight other diseases. But also we lose trust in the system if this is not in a proper way addressed. So, together with the other speakers, UK and Canada, we as the Netherlands, we would really like to push for more transparency. We don't want to hear things from the media. We want more transparency and quick updates, because we think that if we want to fight this pandemic, any pandemic, we need to have the trust of the people and the trust in the system. Thank you very much.
Thank you very much to the Netherlands, and may we now invite Norway.
Thank you, Chair, and thank you to the presenters today. Let me start by underlining that preventing and responding to allegations of sexual harassment as well as sexual exploitation and abuse is a priority to Norway. This has been underlined by our political leadership in letters to heads of multilateral organizations that we support. We were concerned to learn about the allegations of sexual exploitation and abuse linked to the Ebola response in the DRC, and we were pleased to learn that the co-chairs of an independent commission to deal with those allegations had been appointed in October of last year. Since then, member states have several times requested updates on progress and to be able to meet with the co-chairs. Such a meeting did not take place until last week. We regret that it took so much time. We feel that many questions remain after last week's briefing, and we request to be more informed about the Commission's work and would like to know the date of the next meeting when member states will have an opportunity to meet with the Commission. And similarly to colleagues who've spoken already, we're very concerned about the recent reports in the press claiming that the allegations of sexual exploitation and abuse in the DRC were known to WHO staff and that the necessary measures were not taken. We would like to hear the Secretariat's comments to these reports and how you intend to follow it up. Thank you.
Thank you very much, Norway. As we see no further requests to take the floor, I shall hand back to the Director of Governing Bodies, to Tim Armstrong. Thank you.
Thank you very much, UK, Canada, Netherlands and Norway for those comments. We very much appreciate the comments that were made, and in particular in relationship to today's sessions focusing on country level work. Certainly we would be more than happy to organise future sessions where we have presentations in relationship to what is taking place at the country level, and can certainly look to that. Thank you to those countries who also mentioned, of course, the alarming issues that were raised recently in relationship to the SCA issues. The Director General did address these in his opening comments. We certainly will be intending to have future briefings with you, the membership, in relationship to this, and can revert soonest with a date for the next meeting where the Commissioners can come back to you on that. With that, if there are no further questions or comments from Member States, I'd like to thank you all again for joining us today. Jane Ellison had to leave for another meeting. I recognise many of us have another meeting in 2 minutes from now. So on behalf of the Director General and all colleagues and presenters here today, in particular our regional and country office colleagues who also participated, thank you very much, and shall see you at the next mission briefing, which in fact will be some weeks away now. Of course, from next week we have the beginning of our May governing body cycles.
cycle, the PBAC to be followed by the WHA. So we'll see you in June for the next member state COVID-19 briefing session. Thank you so much.